Well, welcome everyone. My name is Mike Galbraith. I'm a primary care sports medicine physician. I practice in the bustling metropolis of East Texas here, and I'm excited to help moderate this webinar series and excited to have our guest, Dr. Michael Swartzon. So just a couple things. First of all, thanks for joining us. This is part of the AMSSM Sports Economics webinar series. Happy to have you. And tonight we're going to be talking about contract negotiation pitfalls. Many of you are young budding physicians, either graduating from fellowship in the near future, or maybe just a young physician and want to have some tips and some tricks about how you can negotiate a new contract. So we're excited to hear from Dr. Swartzon. Maybe just a couple other housekeeping items before we start. Please mute your microphones. We are going to have a Q&A session at the very end. So throughout the presentation, if you start to have some questions, feel free just to enter that in the chat section, and we'll get to everyone's questions to the best of our possibility there at the very end. Also want to remind everyone about the AMSSM annual conference coming up here at the end of April with many wonderful topics and wonderful speakers too. The Sports Economics Committee will also have a few different ICLs. I believe they're all on Sunday morning. Hope you can join us. We're going to talk about 3 topics at that time, and it's basically targeting 3 audiences. It's sports medicine physicians in private practice, and then an academic setting, and more of then an orthopedic multi-specialty group. And that's a chance in an ICL setting to ask lots of questions and hopefully give you some guidance there. The next sports economics webinar will actually be June 25th, here in just a few months this summer. And we will be discussing AI in the clinical setting and in scholarly activity. And we'll be having Dr. O and Dr. Matuzak. So that'll be great. Excited to be moderated by Dr. Edward Smith. So without further ado, I'm going to give you just a little bit of an intro to Dr. Michael Swartzon. He specifically wanted me to give you a really, really long intro, but if that's okay, I'm just going to pare it down a little bit. Just kidding. So he's a primary care sports medicine physician. He's a dually board certified in both family and sports medicine, practices at Baptist Health, South Florida, born and raised in Miami. I've been trying to convince him to be a Seattle Seahawks fan, but I think I failed. He did residency at the University of Kansas Medical Center in the family medicine program, followed by a fellowship at the University of New Mexico in Albuquerque, New Mexico. I believe graduated in 2013. Is that correct?
Fellowship, yeah, 2013.
Awesome. He is an associate professor for Florida International University and also an affiliate professor for Nova Southeastern University, which is a beautiful campus. Uh, Still program director for Baptist Health's Primary Care Sports Medicine Fellowship Program, team physician for the Miami Dolphins and the Florida Panthers. So I assume he's probably a huge fan of Dan Marino and even Tyreek Hill. Other interesting facts I learned, so he speaks Hebrew and attended medical school in Israel. So, and has obviously a passion for not only the economics, billing of sports medicine, provided a great webinar. I think that was just 2-3 years ago. And then now has this contract negotiation pitfalls. So please welcome Dr. Swartzon. Excited to have you with us.
Well, thanks for having me. I want to make sure everyone can hear me and you guys can see the slideshow. I've tried to keep this short, so including this nice intro slide, there are only 21, lots to cover. And so let's get started. So first, for those who are here and those who might watch in the future, congrats on finishing your fellowship, or additionally, congratulations on trying to expand your career by possibly looking for a different position. I want to make sure you guys understand that your skills are in very, very high demand. When I started with my orthopedic group, I was the first one. They didn't know what I could do. They didn't know what we would become. And now there's 7 of us in the program. I've been at schools and teams where the mid and athletic trainer comes from a different program and they had a primary care sports doc there and they go show up and there isn't one where they are, they automatically seek to try and find one. So whether it's in clinic, whether it's in a community, whether it's with a team, your skills are in very high demand. And once you get hired, the basis of your employment is your contract. And so the contract, what's written in it can really make or break your happiness and your success in your career. So we're going to try and go over some pitfalls on what are some unique issues that are for sports medicine, how to protect your time, income, and therefore your career. So first, a disclaimer. I am not an attorney. I'm a family physician with sports medicine fellowship. Almost all of this has come as advice from members to members. So I've polled a whole bunch of members from the board, from team physicians, from other NFL teams, and asked what has been their biggest mistakes, regrets, what would they look for in future contracts, what they wish they had. And so, really, this is not meant to be legal advice. It's really meant to be what mistakes have we made and how can you possibly avoid them? And please remember, contracts are usually state specific. I live in Florida, and so a lot of what I know is from the state of Florida. There are 49 other states out there, plus Puerto Rico and other territories. I do not know any specifics for those, so please bear that in mind. So, as we get started, you are not just a primary care doctor. You are a specialist. In fact, you are a subspecialist. And different employers may have you, you could be at a hospital, you could be at an ortho group, you could be at a university setting, you could work for the government. And when you show up and you apply for a job and the job has a description that matches what you want to do, you may assume that the contract they give you it really matches what you're going to be doing. And I can almost assure you, unless it's a seasoned group with a lot of primary care sports doctors, it will not match what you do. They will throw out a generic contract, which will not serve you very well in the future. One of the specifics when I came to my group, they gave me a contract that was for a family physician and they specifically had no sports in it. And there was one of those situations where the right hand and the left hand didn't really know what they were doing, meaning the docs that wanted to hire me to work with them were not the ones who were in charge of the contract. So make sure you start already with some skepticism and read the fine print. Okay, so what is a contract? The first thing is it's going to have a start date and an end date. That's kind of how contracts work. Whether it's a lease or something else, there's going to be a date where it starts, and that's going to be when your employment starts, and there's going to be an expiration to the contract. Now, many contracts auto renew, and some just have a term with some clauses about how they renew. And so these are the most important things that you got to look at. Is the start date something you can live with? Is the contract period something you can live with? Because if the contract is 1 year and 1 year only, that doesn't leave you very much to get started with your new job. So you want to have security. So you want to have more than 1 year ideally. And if that's kind of how that group runs or that university runs, you need to talk to all the people there and say, well, how does this work? Do they automatically renew? Have there been physicians who have not been renewed? Have they known about it? What's happened to them? Additionally, and I can promise you this happens all the time, your employer may want to add an amendment or an addendum to your contract. And the time they put that in is right at your renewal. So please, whenever you have your contract years coming up, they might send you something and they say, hey, sign this addendum. Please read those. Some of them is just updated language, but I've seen a lot of things that were slightly concerning to me in my agreement, and I've heard of others. I've read, each fellow that's left our program. I've kind of gotten a look at their employment agreement, and they're all a little different. So when that amendment process comes, please make sure there's something in place about how to negotiate that in the future. So as you're looking at your job, the first thing is what kind of job are you looking for? There's all types out there. So you could go out on your own and you employ yourself, write your own contract. You work in a small group, You can work in a large group. It can be ortho sports medicine specific. You could be in a multi-specialty practice. They all have their pros and cons. Academics, government work. Do you want to work full time? Do you want to be a point 0.8 FTE? This is especially true for people who have strong outside interests, family responsibilities. You want to make sure up front that the contract will match what you're willing to do. They always say location is really important. Where do you want to practice? Some people really have a lot of restrictions because they want to be close to family where they grew up, and other people are willing to go wherever the dream job is available. Realize if you're not from that area, the cost of living may change the terms of the contract dramatically. When you're looking at a place, you want to know what their practice reputation is. That may be by asking people you know in the community. It may be a Google search. Not that, Google or Yelp or any of the websites have, the most accurate reviews, but it could give you a good sense of who shows up to the practice and how they're looked at in the community. Salary. This is probably the busiest slide here. Salary is different for every employer you go to, but it really is your compensation package is kind of the biggest meat and potatoes on that contract, and it's usually way, way, way in the back. They have all these preambles and defining terms and go through everything, and you might be on page 7 before you see anything about compensation. And so that may be where you start to go to first. It's not a bad place to start to see if the terms are even close to what you're looking at, but you have to get a sense for how will you be paid for your services. Usually there's a base salary with some type of bonus. Most agreements now are based on work RVUs, and work RVUs are a way that the CMS defines how much work goes into seeing a specific patient or doing a procedure. And it's supposed to take into account the time, knowledge, and experience that it takes to do something like that. So if you look at an evaluation and management of a patient in clinic, a 99205 has a much higher RVU than a 99212. That information is widely available. I would encourage you, if you've haven't learned any billing at all, then and you are going into an RVU contract, you really should learn about it because that is how you're going to be paid. And you may work for a collections model. It may be what you charge, it may be what you collect, it may be a percentage of the profit. I would encourage anyone doing that type of contract to look very specifically at the revenue and possibly get an accountant to look at the books just to see what is reasonable and what you can expect. Some of you may be wanting to be a partner somewhere. That's something we'll talk about. Is your salary guaranteed at all? It's very customary to get a salary guaranteed for a year. Hey, you're just starting out. It's going to be difficult to see the volume of patients, get credentialed with insurances, get your name out there, you get your staff. There's a lot of things that go into when you first start. So you want to make sure your salary is guaranteed and you're not moving somewhere. You're sign this agreement and then you have no pay for the first 3 months. Quality metrics is another way that people are getting paid. And that could be as simple as what is the patient satisfaction score? Or have you completed all your charts on time? Have you done patient education and did you check a weight on everyone that came in your door? Did you click something specific that the healthcare system wants you to click on every single patient? It may seem silly, but a lot of these can add to extra revenue for you if you can meet that quality metric. Extras. So you have the salary. Please don't forget about other things that you may see a high salary and then there are no benefits, or you may look at a contract between two different places that are asking you to work there, and one has a slightly lower salary, but the benefits package may be much more favorable. What if your health insurance was really, really cheap? And, health insurance out there in the marketplace is quite expensive, especially if you have a family. I mean, it may be in the thousands per month. What's your disability insurance? One of the biggest ones, and why I bolded it, is retirement. Most of us finish fellowship somewhere in our really late 20s or early 30s. People who, graduated college and started in the workplace have been saving since they were 21, 22, 23 years old. Compounding interest is really important, and it's very, I think I saw a calculation once where a teacher ended up making more money than a physician because they started working early, had a pension, were able to save early, and just with compounding interest over the course of their career ended up earning more than a physician. Certainly I think physicians make good salaries, but if you don't start saving and if your employer can't help you with that, I don't want anyone on this, webinar to sign an agreement that later will force them to work till they basically can't work anymore. In residencies and fellowships, you had a CME budget. The amount may have been pretty small, like $750. Some employers will give you a rather large CME budget. That may be something that, if they're not willing to budge on the salary, maybe they're willing to budge on the CME. I've seen, fellows who have graduated, when they don't have a large CME budget, they don't attend the same number of meetings. And if that's something that's important to you, it may be hard for you to start paying for those trips like the one we have upcoming to Kansas City if you have to pay the airfare, the conference fee, the hotel, the meals, all the travel expenses. So think about that when you look in your CME. You shouldn't try and just get the typical 750. That won't go very long. Just with a couple society memberships, and you're out of CME pretty quickly. Malpractice, vacation, and sick leave. How are they calculated? How many do you get? Is there actual PTO? Can you cash out your PTO? Moving expenses. Anyone who's moved, is the most miserable experience of your life. Having to pay $12,000 for it is an even more miserable experience. So keep that in mind when you're looking at your contract, because that's another item they may be able to budge on. Signing bonus. Most practices will now have a signing bonus. It is very common for it to be prorated. What does that mean? So if your signing bonus was $50,000, and that's a pretty high number, but I'm just doing it for math, and it was prorated for 5 years, and after 2 years you decided to leave that job, they would ask you back for $30,000. So that's something to keep in mind when you see prorated anywhere in your contract, and that can go with sick leave. They may only give you portion of your salary depending on the number of months you work in a year. So we talk about pitfalls. How do you spot the traps? So they give you this great base salary and they tell you about this production based model based on RVUs. Are they capped at all? And that's a very commonplace practice. So will you be working for free after your productivity bonus is done? You should ask for the RVU rates for other docs in the system with your job, so you have some idea of what you're actually going to be making. I always tell everyone, try and negotiate a floor salary that is commiserate with other people with your years of experience in your location, right? This is where, particularly groups like women and other physicians, can be unfairly compensated because they simply don't ask what are other people making. And if they're not willing to tell you, which they might not, MGMA has the data, and if you can't get that, AMSSM has a salary survey every year. You can kind of see and gauge based on how many years out of practice, what location, what type of practice, what people are making. Please keep in mind, if you are on a compensation model that is based on charges or RVUs, all the sideline coverage, all the training room hours, all the teaching, none of that is covered in your salary. And if that is something that you plan on doing a lot of your time, you need to make sure somehow that's spelled out in your contract so that you're not just giving your time and experience away. Call. Are you taking call? It's interesting, I signed a contract and I don't have any call and I'm very grateful for it, but others may be on call all the time. Are you taking the first call for the ortho practice? Are you covering training rooms as call? Are those calls nights and weekends? How often do you have to do it? Does it go away after a certain number of years? Are you paid for this call, or are you just paid by the patients that you see if they have insurance that's on par and they follow up with you in the office? How does it work? Those should all be spelled out in the contract. And believe it or not, there are people who sign up and then they end up doing things and spending a whole lot of time and they're never compensated for it. They may be happy to do it and may enrich their lives and their soul. But again, the contract should spell out the monetary part. Restricted covenants. This is something that's been in the news a lot. The the government has gone back and forth, and that is the U.S. government has gone back and forth on whether, and that's the FCC, on whether non-compete clauses are good for the economy of the United States. I can tell you that for physicians, non-compete clauses are horrible. In fact, when you look at it, lawyers do not have non-competes. And when you ask them why, they always say, well, everyone should have a right to keep their lawyer, and lawyers are really important. I don't know that anyone would argue that doctors are more important to people usually than lawyers, but yet doctors are not allowed to keep their patients the same way. Most of these restricted covenants are actually very powerful and could be as simple as 15 miles or 2 years from every office that you're at. So if you're in multiple locations, that 15-mile radius will go from each office you're at. Is that something you can live with? If you're moving to a place you haven't been to and you don't have roots, this may not be that big of a deal. But if you're in your hometown and you sign this agreement, and then a couple of years later you find out this is not the job for you, you now have to move. And depending on where the jobs are, you could be moving out of the county or out of the state. So just make sure you know what the terms are and are familiar with them, and specifically what your state law says on non-compete clauses. With every contract, there's always an ending part or termination. You need to read these details carefully. How can you leave if you don't like it? And then you need to see how they can, essentially fire you. Does it have to be with cause? Is it without cause? If it's without cause, how much notice do they have to give you? All right. Some of them, if you're an at will employee, they can fire you tomorrow and now you're out of a job. If you get fired or you leave, is there tail coverage for your insurance? Um, I would really try and push for the longest amount of leeway so that you can get your patients in order and you can get your future job in order. The other thing is the tail coverage. And I just talked to a doctor that joined our group. He came from Chicago. This was planned in advance. Everyone was, they were sad to lose him, but he wanted to come here. They were okay with him leaving. And then as he's leaving, they said, oh, by the way, you have to pay for your tail coverage and you need to give us $50,000 right now. And that's a lot of money. And if you don't know about that beforehand, that's a problem. Think about when you're leasing a car and you turn it back in, there's always some kind of extra fee at the end that you don't understand why it's there, but it's there. And it's in the lease agreement that you didn't read all the way through. With this contract, please read it all the way through. And if you leave, remember, even if it's on good terms, the non-compete may apply. So let's talk about what kind of job you're going to have. So in the contract, it should state what your job description is. So how many hours a week are you supposed to work? Are you, as a full-time employee, are you 40 hours a week? Are you 42? Are you 38? How many patients do they expect you to see in a day? Is that in the contract or not? And then who do you report to? This is really important. You want to know what the hierarchy is. A lot of times you can tell just by who is signing the contract at the end. That is the boss's boss's boss, right? That's who it ends up with. But who do you report to? Is it a physician? Is it an administrator? Is it someone you trust that you've known? Make sure you meet them in the interview process. The rest of these are kind of these extras, right? You go to work, you want to become a doctor, you want to help patients, but there's a lot of other things that go into being a doctor in medicine right now. Maybe you're in a practice where they ask you to do inventory, and by that I mean they may say, okay, which type of corticosteroid do you want, and do you have to go through the equipment? Do you have to go through your budget every year of how much equipment you're going to use and how much supplies? Are they going to have any control on that? If you say, well, I need 21 gauge 2-inch needles, are they going to give it to you? Are they going to say, no, we got these needles and that's it? Maybe it's not important to you. You're dynamic, you're go with the flow, but a lot of these things come in these administrative tasks. Planning today from 5 to 6:30, I was in a strategic planning meeting. Why? Well, we're going over our 5-year strategic plan, and I have to sit there and listen or participate in, what the future of my group looks like. It sounds great. It actually is very helpful. I feel like I'm not just an employee, but a partner. But it's time that I'm not compensated for, that I'm not at home for, and it's a requirement of my job. Maybe your hospital has a safety council or an M&M. Are you required to go to those? Other things that are beyond patient care, are there any sports teams or schools that they're going to have you cover? Which sports? How often? How long is the season? For your patients in clinic, if they call after hours, where do those call go? Is there a PA that's answering them? Do they all go to you? Does it get shared? Those messages that patients send in the portal or by email, are you required to respond to those, or is there someone else assigned to do them? Are you going to be asked to teach? Are you going to be asked to go give community lectures? Are you going to teach CPR in the community? Again, these are things you may want to do. These are opportunities you may love, but it's a good idea to have to know in the contract, is this something that is expected of you? And if so, are you happy doing it? If you're a resident fellow right now, I'm sure there's a lot of requirements that you have to take. um, I promise you, when you're in attending, those don't go away. You have to take ethics. You have to take, how do you transfer patient from one hospital to another? There's a lot of state specific things. There's going to be hospital specific things. Get to know what their annual requirements are, because sometimes these administrators come up with all these courses they think are important, and it's very onerous on the physician's time, and it's usually a waste of time. So keep in mind, if your IT department has you doing all these trainings annually, or the hospital has you attending all these meetings all the time, you should be aware of them so that you know what you're getting into. Location talks about a lot, okay? So you're signing up for this group, and you think they're going to put you in this location X, but actually their plans are to expand, and they're going to put you in this new satellite location Y. How many days are you at Y? How many days are you at X? What is your staffing support? The contract should be specific, if it can be, on who your staffing is, what the model is. Do you have any say in who you work with? This is important because otherwise, as the newest person there, they may give you the worst person they have. They've just been waiting to transfer this person to work with someone else, and that's not fair to you. So just realize that the staffing, and probably equally important, is the equipment. I've heard of fellows who graduated who were told that they would get an ultrasound in their clinic, and then after they get hired, well, the budget wasn't there, or it's coming the third quarter, then we'll do our budget for the next year. It's a long time to wait. It could be years before you get that machine. Healthcare systems or your employer may have their priorities. And if ultrasound or having x-ray in-house is essential to what you do, it has to be spelled out in the agreement. So professional liability, which is another term for malpractice insurance. What are the limits? Is it 250, 750? Is it 1 million, 3 million? Is it 2 million, 5 million? Just what are the limits? Are you getting tail coverage? If there is a lawsuit, who covers the litigation? Do you have any say, or can they settle just because they decided to settle and you felt like, well, we shouldn't settle because I didn't do anything wrong? That the choice may not be up to you, even though you're the one that's named. So please make sure you read the fine print on the malpractice coverage. Does it apply to sporting events that you cover? And then there's another term called indemnification. Again, I'm not a lawyer. So in this case, I asked Chat GPT, how do I explain indemnification to sports medicine physicians? And this is what it came up with. And I kind of paraphrase and change it around. But essentially, who is to blame? Right? That's what indemnification is. So if something comes wrong, who is to blame? And will one person protect another one? So when you're with your employer or you're with a team, you do not want to sign away that all the indemnification is for them and you take all the liability, all the loss, all the damages, any negligence, all the costs are all on you. So you want to make sure, and this is more for teams and sports stuff, but you want to make sure you know who's covering the legal fees, and is this going to be something that we protect each other? So I'm there to help the health system, the health system's there to protect me, or is everyone on their own? If you want to look into a partnership track, seems very attractive, right? You want to be a partner in a group of physicians. You've seen this group; it's been very successful. You see that they look like they're doing well financially. You like that kind of model where you're a business owner and you share in the profits, you share in the ancillary revenue, and there may be an opportunity for you to buy in right away, or maybe it's a little delayed. You say, well, you know what? Why don't you work with us for 2, 3 years? And then at that point, we can revisit the partnership. All those need to be in the contract, right? If your expectation is to be a partner in 3 years and it's not written there, but they told you, well, in 3 years, we'll look at it again, that may not apply, right? They may change their mind and say, well, we don't want to offer you a partnership track. What are the buy-in terms? And there's a lot of hidden costs that can go into this. And if you are looking to go into a partnership trap, again, I would highly recommend you hire an accountant who's very knowledgeable at doing the forensics on these small practices, medical practices, to see how are the revenues divided, what are your risks, how much you have to pay, because if the business loses money, you may be required to pay in. You may not get the money that you're hoping. And I've certainly seen practices in this area that have gone out of business due to administrators embezzling and poor business decisions. So you go into it with hope and you want things to succeed, but certainly the fine print can matter. So you may say, okay, you talked about indemnification, litigation, all these terms. You read the agreement, it's 13 pages long in small font with words that you're not familiar with. You're used to reading medical journal, which has very complicated vocabulary, but the legalese you're not sure about. Hiring a lawyer makes sense, right? If we wanted a medical opinion from about the kidney, we may call a nephrologist. So why not call an attorney? It's a pretty good idea. You want to try and find someone that has healthcare experience. You want someone that can look over the contract and translate it into layman's terms and try and suggest alternative language, at the very least, let you understand what you're getting into. Even if it's not ideal, at least you know. Now, remember, with attorneys, they love doing things by the hour. And they may give you a relatively reasonable rate. Say, oh, you're just coming out, I'll charge you, 200 an hour and we'll do this quick. Every phone call they make, every email you send, every time they meet with someone, those hours can add up very significantly. So my advice is to try and find a lawyer for a flat fee. It may be 1,000 or 2,000, but at least you know what the cost is and you can budget for it. Again, it's up to you. You may have a family member or a friend. My advice is to try and use a professional and not someone you're related to. But again, that's your judgment call. The second part is, do you want the lawyer to negotiate on your behalf? And think of it like in sports, like they have agents, right? Agents do all the arguing and the agents do the heavy hitting with the teams, so that the player doesn't have to have that argument. It kind of leaves the player clean. It keeps you out of the melee of the redlining of a contract. Just remember, you get a shark or you get a lawyer that's fighting hard, that may reflect on you, or that will reflect on you with your employer. So what else can be in a contract? You can have a lot of clauses, right? And those clauses are usually to your benefit more than they are theirs. These are things that you may add. You may say, I want to carve out time that if I want to do consulting speaking work, which can be quite lucrative. Maybe you want to do some legal work, testimonies, cases. If you're a full-time employee with no clause about doing this, they may say, well, either you can't do it or all that money comes to us and you just get the RVU part of it. That's not fair, and you should try and work that out sooner rather than later. Are you given an administrative role or an academic role? How is that worked out? Do you get a stipend? If you get an NIH grant and you're doing research, where does that money go? Do you get to keep that money, or does that money go into a big fund? Now, team coverage. This could be an entire lecture of itself. You could go work for a high school, you could go work for a college, you could go work for a professional team. They all have their pros and cons. I want you to understand what you're getting into. Typically, with high schools, and we have this high school toolkit that the AMSSM has made. Um, One of the things you're doing this mostly is volunteer work. It's good for the practice. It's good for the soul. I encourage you to do that. But you have to protect yourself in terms of liability when you're covering those events. And you also need to think, well, this is going to be great for my practice. And then find out most of the kids in that school are uninsured or have Medicaid, and you don't take that in your practice. That may not be that great of an arrangement, especially, and not even financially, but even for continuity of care. If you can't make sure these kids get well, it really is burdensome on yourself, not only financially, but aggravation of you wanting to be a good doctor and you can't be. Colleges typically don't have money to pay for physicians. It's not really in their budget as much as you would think. And depending on the size of the school, and how needy they are, it could be very time consuming. And professional teams think you need them more than they need you. And so that's kind of how the negotiations start. I know, I started working with the Dolphins 12 years ago, and we had a survey at the combine, and a third of the teams in the NFL were unpaid, completely unpaid. And it's an enormous amount of work. I think that's gone away, but certainly there are teams that pay a very small sum, and there are teams that pay more. And that has a lot more to do with your relationship with the owner, your years, there's a lot that goes into how much you're paid with the teams. So certainly you want to think about that. How much travel is there? How much time commitment is there a requirement to do training rooms for 2 hours twice a week? Do you have to drive to the training center that's 30 miles away? Can you be there at 7 a.m.? Maybe you're an early riser, get it done, and then go to clinic. Maybe they want it at lunchtime and they kind of kill your whole day. So try and get those things spelled out with the team. There are benefits. A lot of teams will give you tickets, they'll give you gear. I won Stanley Cup with the Panthers. I got a ring that's enormous. I love it, but I also missed 26 days of clinic during the playoff run. And those 26 days are not really accounted by my employer or the team. So you need to be very careful what you're getting into. All right. So, what are the last kind of conclusion tips? The contract is not about winning and losing. Try and keep that in mind. They want to hire someone, you want a job. Try and get to that win win. The contract is definitely negotiable. It should not be you see it, you sign it. But understand there's going to be terms in there that are non-negotiable for the employer, whether it's to keep things standard across the healthcare system or there's just a line they're not comfortable with. Realize that there are things that they're not going to budge on no matter how good you are. My advice is always to try and start with the easy stuff. That way you make some changes, you get moving, and then when you get close to the end, that's when you might start with something bigger. Because if you start out the beginning with something bigger, you might not get anything else, or it may be over before it starts. How you do this will be remembered. At our company picnic, I saw the HR person that hired me. We're still smiling and friends because it was a difficult process, but it was a successful one. And when it's very difficult and you're making things very hard on yourself, with the contract, when you start out, it kind of is like you're starting off on the wrong foot. Everyone's like, oh, this person was such a pain. They're so difficult. And that's how you start. So just be careful with this contract because it reflects on you as a person. There are about 200 fellowship graduates a year. This is not a field where there's thousands upon thousands coming out. You are in very high demand. You want to make sure you know that worth, especially if you're in a market that's not saturated. They should want you more than you need them. So keep that in mind. Do not agree to any verbals. Please get things in writing. Verbals sound great. Everyone's smiling. They're trustworthy, shaking hands. But if it's not in writing, it's going to be a problem going forward. I do recommend you consult an attorney, and no matter what they give you, please give yourself 48 hours to read and sit on it before you sign. So thank you very much. We still have 16 minutes left for any Q&A, and thank you very much for your time. Mike, I'll send it back to you.
Awesome. Thank you, Dr. Swartzon. Appreciate your great comments, wonderful slides. I think this is just great information, like we said earlier, not just for that fellow that's preparing to graduate and enter the workforce, but boy, there's a lot of people. How many physicians actually change jobs within the first 10 years? Most docs change usually within the first 3 years. Not to be too transparent, I've been in practice almost 15 years and I'm on my fourth job. So I think this is some great, wonderful information. Maybe we'll go to the chat box here, look at some of the questions, and feel free those. If you still have questions, feel free, you can enter that into the chat there as well. There's some comments about finding details about the AMSSM annual meeting, which you can click on that as well. Elliot Hu has commented too about it's now common since the COVID pandemic to add an addendum to start to cover staff or for staff to cover things like inpatient and emergency. Boy, that kind of opened our eyes a little bit, right? We didn't even think about including that in contracts. There's some comment about, um, let's see.
It's about paid time off. Ellie makes a really good point because I talked about the addendums. It may be something small that may not apply to you. I remember I saw one addendum about, hey, we don't want any physician posting patient pictures or surgeries in social media without our explicit approval. Okay, I mean, I could see where that goes, but reading the language, it almost read, "Wait, I can't post to social media ever, even if it's my own thing." And so that's something that's simple, but to his point, if they add something that causes you to lose something that you've had, and your agreement, if you say no, they say, well, okay, so our we're done, and now your non-compete applies. That could be very, very quick turnaround for you. In 30 days you have to not find another job 15 miles away. That's a lot.
Mhm. Marcia asked a question that says, what are some examples of questionable addendums?
Right. So they fortunately, I have a very ethical employer, so I haven't had to deal with too many. But they, let's say, the in 2021 the work RVU numbers changed for the CMS, and they expected everyone to follow suit. Let's say your employer set an addendum saying, well, we think it's fair to keep the 2020 rates, which essentially eliminates your raise. What would you do? Right? I think they can kind of force you to do whatever they need with those addendums. That's not really the point, but they could, especially if your employer was now you're with a practice that was bought by a venture capitalist, and now there's a board of business people making decisions on healthcare, and they're making financial decisions that you don't feel is right for patient care. And they might say, hey, you can't leave work for a doctor visit without us getting a doctor's note. Imagine a physician needed to come in for with a doctor's note, but there are places that do that, and it may not be in your original agreement, and then they may say, you know what, we've done a template utilization review, and we found that you're not seeing the number of patients that you need to see per workday, and so they change your agreement to how many patients specifically you need to see, whether you have the staffing or the will, or maybe your patients happen to be more complex. It doesn't matter.
I thought it was really interesting too and important that you included right at the get-go from your contract that you start talking about termination clauses. And I think that's really important. You talked about termination with cause versus termination without cause. Can you maybe comment a little bit about the difference between those two?
Well, it's interesting because depending on the state you're in, different rules apply.
Mhm.
Without cause basically says, they want to move on because you're not a good fit, or they want to dissolve the orthopedic part of their practice, or they rather switch to APPs instead of physicians, and they say, look, this isn't working for us, whether they're closing that office, or so it's not you, it's me. That's essentially the without cause. And with cause is tricky. Let's say you accessed celebrities patient chart, a blatant HIPAA violation. You repeatedly came to work late, and no excuses, and they tried to remedy it, and you just couldn't get there on time for whatever it is. Um, and then they could say, well, you're fired due to these reasons, that you did not fulfill the duties listed in your employment agreement, and you have 30 days, and they may ask you to leave that day,
Mhm.
right? And they just pay you the 30, and they say you're done, you're closed off from the system, your emails turned off. If they gave you a phone, they take the phone away. If they have the laptop, they take the laptop away. And that's it. You're cut off. Your badge is taken, and you now need to find another place of employment. Does that kind of
Yeah.
explain it?
No, I think that's great. And I think it's really important that physicians be aware of, if you're terminated without cause, what does that mean? So I think that was good. You gave, I think, some really good examples too. Um, a few other questions here. Post-it says, is it reasonable to compare multiple contracts to use as leverage for negotiations, whether that's salary, CME, benefits, etc.?
Yes, it is. I think it's very reasonable. You may think you're trying to dupe your employer, but really this is a serious business matter. And if you have if you want to work for X, and I don't mean X formerly known as Twitter, just Hospital X, and
Mhm.
you have an employment agreement offer from Y, um, you can use Y as leverage for X. This is a very common practice. And in fact, while I feel sorry for Y, if I was X and I want to hire a physician, one of the ways I can get my administration to hire someone quicker is they have an agreement somewhere else. Like, hey, we're going to lose this physician, him or her, very quickly if we can't get something out and let them know that we're serious. So I do think having multiple contracts is important. It does bring up something I didn't put in my webinar, is letters of intent. Many times, letters of intent are binding. So if they give you a letter of intent and it's a one pager and you sign it, uh, that's it. You're kind of on the hook. It's like the match or early decision in college. Well, it's binding, and while there are ways to get out of it for the employer or you, if you move forward, the terms that are there are now the terms. So if you're like, well, I was hoping to negotiate this or negotiate that, if it's in the term and you sign letter of intent and you signed it, that's going to be a difficult position for you to move forward on. So be care of those. Those are very powerful mini contracts.
I think that's some great insight about the letter of intent as well. I want to make a comment just going back to what you'd said about maybe using these multiple contracts for negotiation leverage. I think as physicians, sometimes we forget most of these big corporate healthcare systems are led by people with many years of business, and they are used to crunching numbers, looking at data, and negotiating. That's what they do professionally. And they know that they can prey on typically young, ignorant, naive, altruistic physicians, right? Who are very reluctant to negotiate or negotiate softly. So I think that's such great advice is I think, and I like what you said, starting, maybe you start with the small stuff, but I think you need to have some of those hard conversations and use those contracts to negotiate for some great contracts down the road. One other question says, how do you recommend including compensation for sideline coverage into contract that's RVU based?
Uh, Very complicated.
Yeah.
I would say there's a couple ways to think about doing it. The most direct way, my recommendation would be to negotiate with the team itself. And that may be complicated if your employer says, well, you're a full-time employee, you can't take a stipend or a salary from an outside company. Again, something to work out in the agreement, but it makes it a lot simpler, because that way you can agree to something with the team. The team knows what they want. The team wants you. You want to be with the team, and you can figure out a per season or per game or some kind of terms that are mutually agreed upon, as opposed to the employer negotiating on your behalf, taking overhead, and really may not give you anything. So I would recommend directly getting it from the team. Otherwise, there should be a separate schedule in your contract for how to pay this. And depending on your employer, they may have a consulting firm that would do a fair market value of what covering 3 hour high school football game is versus a 3 hour college game versus a 90 60 90 minute basketball game for a professional team. They should have those numbers. If not, they can hire a firm to get them, or you can propose it and you could say, this is the data I've got. Most leagues have a physician society that will give you some of that information to use to negotiate on your behalf. I do think this is getting better. I do think that you should try and get paid. I mean, I had dinner with a Wall Street friend of mine from college, and he was like, "So what do you do at when you cover a Panthers game?" And he's like, "Well, I said I watch the game. I wait for something to happen." And he's like, "So what happens?" And I was saying, "Well, in the last game, one of the opposing team players had to be evaluated for a concussion." He's like, "Oh, so you did that?" I said, "Yeah." He's like, "So did the other team pay you to do that?" I was like, "No." I said, "Did your team pay you to do that?" "No." Did you is if something happens, are you at fault? And I was like, yes. He's like, well, that was stupid. He's like, what happened next? He's like, well, the official got hurt and needed stitches. He's like, oh, so did the NHL pay you to do the stitches? I was like, no. And he's like, was the liability yours? I was like, yeah. He's like, how dumb are you? And it's just because we've all done it for so long this way that we don't realize how dumb it is that we're giving away our knowledge and experience and accepting all the liability for doing all these events. And again, you want to work with challenged youths or underprivileged kids, or do CPR training in the community. They're things that warm your heart, that are worth more than money. But then, when you're on the sideline of a match or a game, or in a court, and you look around and every single other person there is making money because that is their profession, and you're standing there and you're doing what you do as a professional, but you're not making any money. I think that hurts, right? When the photographer and the official and the coach and everyone there is making a salary, yet you're the one expected to do it for a couple tickets and a hat. um so I'd be very careful with that, and I would try and get direct compensation.
It's interesting you use that example too. I practiced in Canada for 11 years where my wife's originally from, and I was the head team physician of a minor league hockey team in Alberta. And at the time, they were desperate for physicians. I was a young physician, excited to jump in, provide that coverage. And then I realized, I was just getting burned out covering so many home games, as you can relate to, right? And then I realized a few years in that I had negotiating power. And then I learned, okay, here's the standard rate in Canada for event coverage. And again, had that ability to negotiate, say, I just can't continue doing this unless this is met. And I recognized that there was that pay discrepancy. It worked out well. To go back to that same comment too, I think it's an important either addendum or clause that you include in your contract saying, are there any restrictions on outside work? Whether that's moonlighting or can I be employed to do other work to open that avenue to see if you can get coverage for that sideline. One last comment I see written here in the chat box. It says, "How do you navigate getting appropriate compensation for advanced procedures like BMAC?"
Yeah, that's a good one. These have been phenomenal questions, because these are still challenges that I have today. So I want to make sure you understand that whatever's going through your mind about how difficult this is, those of us who have been in practice, 12 years, still have trouble with this. So to put this in perspective, instead of just calling it BMAC, I would call it a cash-based procedure, right? So if you are on a work RVU model and, the patient has to pay cash because it's not covered by insurance, and the practice comes up with a price. So let's say the BMAC is, I don't know, $3,000, right? So how does the physician get paid? If your salary is based on a work RVU and BMAC has an RVU value of 0 or PRP, or it's very complicated. And again, my advice is, for something like that, if you contact the companies, the rep for the companies, they will usually share data of other physicians in your area, or whether you're a private practice or academic practice or mixed practice. Um, they will show what some, normative values are. Or again, you have this collective group with AMSSM. Call your buddies, call your
Mhm.
colleagues, and say, hey, what are you getting for this? How did it work? How did you negotiate that? And some people negotiated well, and some people negotiated poorly. Um, and sometimes it's what the group is willing to give, right? So if you're doing a BMAC, and let's say you're charging 5,000, you say, well, out of that 5,000, 1,000 goes to the kit, and maybe there's another 1,000 overhead for the practice. So there's 3,000 left. What would be fair for me to accept for payment when I'm the one doing the procedure? I'm the one doing all the work. I'm accepting the patient. Is it half? So do I get 1,500 for doing the BMAC? Well, if the orthos hear that, some of them are getting paid like 300 for an arthroscopy, and they hear you're getting 1,500 for a BMAC, that can lead to a lot of difficult discussions when, they say, how can you make more during doing this when I make less doing surgery? Unfortunately, it should be, congratulations, you're able to make this amount. I'm happy for you. And everyone should be fighting for physicians to make more money, not for us to be sitting at AMA meetings yelling, why is the other subspecialty making more money than I'm making? It should be collectively we try and ensure that our compensation is fair. And I think in a cash-based model, it's tricky.
Well, that's wonderful. Thanks again, Dr. Swartzon. I think we're kind of wrapping up here. It's been an hour. Wonderful presentation, and I think we had a lot of great and engaging questions as well. Maybe just to conclude, I'll reiterate as well. We do have the upcoming AMSSM annual conference in Kansas City coming up the end of April. There in the chat comments, we have the link again to the conference. So this webinar is sponsored by the Sports Economics Committee as part of the AMSSM. We're going to have another webinar sponsored by the Sports Economics Committee on June 25th, just this summer, in a few months. And we're going to be discussing artificial intelligence in the clinical setting, and also using AI in scholarly activity. At the upcoming AMSSM annual conference, just a reminder too, this Sports Economics Committee is going to have 3 amazing ICLs talking about finding a job as a sports medicine physician in private practice, one also in an academic setting, and then number 3, and more of an orthopedic multi-specialty group. So hope to see you there. Would love to have you. That's bright and early, some of those ICLs. Thanks again, Dr. Swartzon, for your time, and I guess we'll check out at this time.
All right, great. Thanks, everyone. Have a good night.
Thanks.